Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. This is Dr. Habib, and I am here with JP. How are you, sir?
I'm doing great. Glad to be here.
This episode of the Health Upgrade Podcast is brought to you by Truvaga. Have you been looking for a simple way to feel calmer, think clearer, and sleep better? Imagine achieving this with just 2 minutes a day. I'm excited to introduce you to Truvaga, a handheld device that supports your nervous system through gentle vagus nerve stimulation. As a doctor specializing in functional health and wellness, I've seen firsthand how Truvaga has accelerated healing in my clients. I've used this device to help people with a range of issues, from sleep disturbances and heart palpitations to digestive dysfunction, nervous system imbalances, and mental wellness concerns. The results have honestly been remarkable. Truvaga is designed to catalyze and accelerate the shift in your body from fight or flight to rest, digest, and recover mode, helping you manage stress, maintain mental clarity, and unwind more easily. It's not just theory. I've witnessed its positive impact on real people facing real health challenges. The best part? Truvaga fits seamlessly into your routine. No need to carve out hours for wellness. Just 2 minutes a day can make a difference. It's a small investment of time for potentially significant benefits in how you feel and function each day. If you're curious to experience Truvaga for yourself, visit truvaga.com/upgrade. You can save $30 on your device by using the code UPGRADE30 at checkout. Remember, that's truvaga.com, truvaga.com/upgrade. It might just be the first step towards a calmer, clearer you, just as it has been for many of my clients. I woke up this morning with a bit of a headache, and I thought it was very timely. I didn't have a migraine. I don't think I've ever suffered from a direct migraine, but I woke up and my neck was just incredibly tight, and I just had this dispersing pain both sides, but it was just kind of a low-grade pain throughout my upper neck and back. And I immediately said, I need a chiropractic treatment. I need to go see my chiro, who just happens to be off on Tuesdays, which today is a Tuesday that we're recording. And so I said, okay, well, what's my next option? And I said, I should absolutely go and stim. So I absolutely went and got my vagus nerve stimulator. And we were actually planned to be speaking on this topic today anyway. And I just thought it was just timely for me to have a crappy headache, because after using my vagus nerve stimulator, I feel capable of doing a wonderful talk with you on the topic of migraine and the vagus nerve, how it's connected. So I'm excited to dig into this topic with you, something that you are very aware of based on the history of you and the team at electroCore building out the Truvaga device.
For sure. About a decade of time, maybe a little more, focusing on headache. It's a fascinating topic, and I'm glad to see it worked for you. You know, nothing ever works 100%, but the effects on headache are pretty positive and pretty consistent. So that's good to hear.
So let's dig into this topic, particularly migraine. We're going to dig into migraine specifically today. There are multiple types of headaches. We know this, but migraine is unique, and I want to get into that with you.
It's interesting that you say that, and I was going to comment, and now that you brought it up again, I'm going to say it. It depends on where you are geographically, and that's a bit tongue-in-cheek. But in the United States, there is no reimbursement, or has been historically no reimbursement for managing tension-type headaches. So in the rest of the world, it's estimated that 70% of all headaches are tension-type headaches. But miraculously, in the United States, we don't have them. We only have migraines. Now, I say that tongue-in-cheek, but it's a function of what gets reimbursed. And
interesting. That is a very interesting finding, yes.
At the end of the day, yes, there are tension-type headaches. And what does that really mean? It means the tension is the cause, okay?
Yes.
Just a little historical note there for people.
So let's dig into the understanding of migraine, maybe a little bit of history as to what migraine has always been kind of thought to be over the last few decades with regards to the science of migraine and how people suffer from it, what the experience is like. We know there may be some triggering foods or exposures that can play a role in this. Let's talk the science of migraine right off the bat.
Sure. So you said history. So the history of migraine goes back to prehistory. Obviously, human beings have been getting headaches from the dawn of the species. And there's even cave art in the caves in France from 30, 40,000 years ago showing depictions of people with headaches. And there's been all sorts of different approaches, whether they be spiritual or quasi attempts at medicating for headaches. But, we've suffered with them for a long time. The interesting epidemiology of it, if you will, is that headaches are predominantly a female health problem, or at least migraines are predominantly a female health issue. And it's not 100%, of course, but probably 3 out of 4 people who suffer with migraines are female. The prevalence of migraine in children is basically about the same between males and females. And that when women go through having their first period and going through puberty, that's where you get this, emergence of migraine in the female population. In fact, the age at which migraine first shows up, they call it the penetrance of migraine into the population. The number one age is for females at age 13. So, we think of migraine as being something that's more of an adult problem, but it actually arises during puberty. And the prevalence of migraine for women is, between the ages of 13 and 60 is about triple what it is for men. As I said, it's like 3 out of 4 migraines are suffered by women. And then once they go through menopause and they're entering sort of the older age, it comes back down. It never actually meets back up with where the men are, but it does come back down. And so, of course, that suggests that there's some relationship between fertility and the suffering of migraine, which brings the thalamus and circadian rhythms and other hormonal rhythms into play. And of course, lots and lots and lots of effort has been spent trying to figure that out. And of course, they study menstrual migraine and menstrually related migraines, because even among the female subset of patients, the occurrence of migraine is much more prevalent during that period of going through having your period. So just a little background on when it occurs and who's experiencing them, which is interesting because men actually suffer with other types of headaches with greater frequency than women. For example, cluster headaches, which are called the suicide headaches. They occur probably at least 3 out of 4, more likely among males, which sort of suggests that maybe they might be a little different in their causation. Yet to fully understand. And if you talk to the average neurologist, he's going to say, we still don't understand where migraines come from. I think to a certain extent, that's a function of the fact that they haven't really accepted the role of inflammation in migraine. They still think it's either a neuronal problem or it's a hormonal problem. I think they even will accept that it's a vascular problem before they'll believe that it's an inflammation problem. But you and I know that there isn't any pain, there isn't any experience of anything going on in the body, certainly not in the brain, that doesn't include inflammation.
Yeah. Inflammation is that common link, right? And the localization or the specific type or area in which that inflammation is occurring is going to result in certain types of symptoms. And we just need to understand that there's a pattern involved in creating a set of symptoms that we then have labeled as a certain diagnosis. And so that patterned inflammation or that patterned piece needs to be understood, and understanding the root causes behind that is really what practitioners like myself spend our time doing, trying to understand those root causes. What are the triggers of that inflammatory reaction in that piece? And we've talked about this dozens of times on the podcast. Controlling inflammation is the key. Inflammation in itself is not a bad thing, but controlling that inflammation is key here. And that's where the vagus nerve really comes in, right? Vagus nerve is the linchpin in that controlling piece of sending out inflammatory control signals. For the signals from the gut to get up to the brain, the microbiome gut-brain axis is absolutely linked there. There's a big role to play for nitric oxide, which we'll get into as well. There is a big role to play for nitric oxide being the good or the generally considered good forms of nitric oxide, which is those created by endothelial nitric oxide synthase or neuronal nitric oxide synthase, versus the bad version of nitric oxide, which is created generally by macrophages, but immune cells in general that have the inducible nitric oxide synthase, iNOS form. And that is going to produce significant levels of nitric oxide in that inflammatory process. So we need to understand that there's a direct link here to controlling inflammation, downregulating inflammatory markers, and the entire inflammatory process. Because when we don't control inflammation, this is when we get into the diagnosable states of disease.
Right. And we can bring this back around and sort of close the loop on this, because bringing up nitric oxide brings up, what is one of the important things that nitric oxide is supposed to do? It's vasodilation, and it's controlling the vasculature. And we mentioned that, headache neurologists will begrudgingly talk about vascular headaches. So one of the early recognitions was that drugs or medications or chemicals, plant-derived chemicals, that have an effect on vasodilation versus vasoconstriction can have an effect on headaches. And so one of the earliest medications that was developed that was really specific for headache was something derived from ergots, which is a plant. And what they did was they derived ergotamine. And there's hydroergotamine and ergotamine, which are very, very strong vasoconstrictors. In fact, they can have cardiac effects as well. And what they used it for was for headaches in very minute quantities, that it would cause the vasculature in the head and the brain and surrounding the brain to constrict, and that would be beneficial for headaches. Now, so what did that suggest? That suggested that when the blood vessels are dilated, and in fact, we can trigger, in migraine patients, you can trigger migraines by sort of forcing the body or exposing the body to high levels of nitric oxide. Okay, that's why when somebody says, hey, nitric oxide is wonderful, my head in the background, I'm thinking to myself, yeah, not always, okay? Because if you're a headache sufferer and I give you something like, a nitroglycerin tablet, which is an NO donor, donating nitric oxide, I'll trigger a headache, okay? And I don't want to do that, obviously, but to test whether you're a migraineur, they do those sorts of tests. And in animal models, we do that. So the idea that the blood vessels becoming leaky because they're so expanded and so dilated that they're leaking fluid and potentially immune cells into the brain and into the dura and the tissue covering the brain, which is actually where the pain sensors are. And I think that's probably just a momentary tangent. When we have a headache and you say, oh, I've got this pain in my head, and we sort of localize it inside our brain, there are no pain receptors inside your brain. They can do open brain surgery. I mean, literally just with a little local anesthetic on the skin, burr a hole in the skull and go into the brain, and you will not feel it. You may experience some strange things that are being triggered by different areas of your brain being touched, but that is not painful. But headache pain is actually caused by inflammation and blood vessel dilation and extravasation, which means the leaking of fluid from blood vessels in that structure. So you ask, well, okay, medications that close off that or tend to shrink the blood vessels back down, like ergotamines, you can understand why they would be a successful drug. As the field sort of evolved away from ergotamines, because they're dangerous, and there's a whole story about how ergotamines were delivered, and believe it or not, witches and the entire original concept behind or the origination of witches riding on broomsticks. All of that actually comes from that whole history. We won't go into it, but it's kind of interesting for those people who are interested in that sort of stuff. But when they moved away from looking at ergotamines, they started looking at other compounds and chemicals that could be beneficial for headaches, one of which were anti-inflammatories, like aspirin, okay? Which, to this day, nobody fully understands what aspirin does, but acetylsalicylic acid and its COX-2 inhibition or broad-spectrum COX inhibition is suspected to be part of it, which is, again, part of the inflammatory process. And we know that we can trigger migraines in animals by exposing them to pro-inflammatory mediators like prostaglandins and bradykinins and things like that, just literally delivering it directly onto the brain, that will cause headaches. So inflammation is involved. But they started moving away into areas when they developed a class of drugs called triptans that modulate serotonin receptors. And so there's this belief, okay, well, serotonin's involved. So now we got to figure out, well, it must be a neurotransmitter issue. And, and by the way, people who have epileptic seizures, well, they end up either beforehand or typically after having a seizure, they have terrible headaches. And they're very often, they're migraineurs also. So there must be some relationship between the neurotransmitter imbalances that they have. That must be the real cause of migraine. And again, that's just a symptom of what the real underlying problem is. And so we have to sort of bring those worlds together and say, okay, what mechanism is it that would underlie the blood vessels dilating and the changes in neurotransmitter expression and neurotransmitter problems? Well, it turns out that's inflammation. Inflammation does those things. So it's not rocket science to get there, but we're still sort of pulling people. There's still a lot of the neurology field that thinks that inflammation is an afterthought. It's not something that really matters.
I think that's really how we can put a microscope on how the healthcare system currently works, or how it has been working for quite some time, is very much focused on the symptom, right? Symptom-focused treatments, that the symptom is the problem, and let's suppress the symptom. When in reality, we have to look deeper to figure out what's causing that symptom in the first place. Now, yes, obviously, we want to eliminate the experience of that symptom, but that symptom is there in the first place to try to tell us that something underlying is not working correctly, or something is out of balance. And for me, the thought process here, and I think it aligns exactly with yours, is that deeper cause. Something triggered that inflammatory process to occur, and something is not allowing that inflammatory process to be limited, to be knocked down, right? To be controlled. And so understanding what some of these triggers are that could be causing the inflammation in the first place, we need to really dig into that. I'm a big fan of this bucket analogy, that we've got a certain amount of stress and, different types of stressors, daily stressors, psychological, physical, and biochemical stressors that our bodies can handle at a certain time. And once that bucket fills up, if we don't do the work that's necessary, the self-care foundational work to empty or drain that bucket out effectively, the bucket's going to get to the point where we start overflowing or we fill up. And then just little drops of additional fluid can overflow that bucket very easily. And that is where a lot of migraineurs tend to be sitting. From a clinical standpoint, most of the time that bucket is very close to, if not completely full, and then some new trigger. It can be a food sensitivity. For some people, it's things like chocolate, coffee, certain fruits can be triggers for these people. That's a trigger that initiates the inflammatory response, because now the bucket has overflowed and now we're initiating an inflammatory response, and we lack the ability to control that inflammation, which is vagus nerve linked. So when people come to see me and they've been dealing with migraine or some sort of headache issue, I'm always first looking at what's filled the bucket in the first place. What are all the stressors that have caused you to get to this point, so that we can, at the very least, lower the quantity of fluid within that bucket first off, right? So that the next time you're exposed to coffee or chocolate or whatever that trigger was for you, it's less likely to cause the overflow to occur. And then what are the foundational things that we need to start to work on to address those things? So from a clinical standpoint, we're aligned here, talking about it's inflammation that is really the underlying pathway that leads to these conditions occurring. The root causes are going to be individualized. Migraine can be linked very heavily to certain microbiome markers, specific bacteria, parasites, viruses, yeast, worms, providing biochemical stress. It's directly linked, as we saw, if there's a leakiness that occurs in the brain, blood-brain barrier leakiness, gut is often the root cause. Leaky gut, leaky brain, right? And so the gut is where all of the toxins enter our body, but it's also where the good stuff comes in. We need to note the effect or the current status of the gut function, the gut barriers, right? So let's talk about some of the triggers. I've mentioned a bunch. I think there's something you got there.
Yeah, no, and it's just interesting to me when you talk to headache neurologists and they espouse this idea that it's not an inflammation process, it's a neurotransmitter issue, or they refer to as CGRP, and we'll get into calcitonin gene-related peptide, and the fact that inflammation is actually the thing that drives the production and release of CGRP. But what I find so interesting is that if you're a patient and you go to a headache neurologist, one of the very first things that they're going to do is begin trying to identify your triggers. Okay. So they use the word trigger. Okay. So it could be the things you're talking about, coffee, it could be stress, it could be some fruits, it could be fish, it could be alcohol, it could be a number of other things. And you think to yourself, well, wait a minute. If I have a food sensitivity that is leading to me having headaches, what is a food sensitivity other than activating an immune response? An immune response would entail inflammation. So their very first strategy in managing a headache patient is to admit that it's an inflammatory problem.
Without using those words. Sadly.
Without using those words. So, I mean, I don't even know if they think that way, but I mean, it's just, that's what you're doing. That's the strategy you've been taught, is to eliminate the inflammatory trigger. Okay, so one of the other things that's really important, and we haven't yet brought it into the picture, but into the equation, but it belongs there, is what's the easiest way that you can give somebody a headache? I mean, other than hitting them the head with a brick, is deprive them of oxygen. In a low oxygen environment, you get headaches. You go climb Mount Everest, you're going to spend weeks in base camp with dull headaches. You go skiing, what's one of the symptoms of altitude sickness? It's a headache. Okay. Being deprived of oxygen is by definition stressing your mitochondria. Okay. And when we look at, things like stroke, because obviously what's one of the symptoms of having a stroke? A really bad headache. Okay. What is causing, and again, the tissue that is dying in a stroke is inside your brain. Okay. That tissue is not getting oxygen and it's dying, but there are no pain receptors there. So why would you be experiencing pain? Well, the answer is that the mitochondria are stressed. They are triggering inflammation. The inflammation signaling gets into the bloodstream and activates your entire immune system. And your immune system recognizes the concentration of that signal is coming from the brain. And therefore, it will cause you to perceive the pain in your brain, in your head. So again, it's all a process of how inflammation and how your immune system is responding to damage. So again, if we take it back to the medication side for a second, one of the other classes of medication that is really interesting for us to talk about is epilepsy medications. So epilepsy medications have this sort of interesting phenomenon that they get developed for the treatment of seizures and they end up in other areas. Okay, for example, Neurontin and gabapentin, which are drugs used to treat fibromyalgia and other pain conditions, and even to a certain extent, can be used for certain psychological disorders, was originally developed as a treatment or treatments for epilepsy. Topiramate was another drug that was used to downregulate the excitability of the brain, the excitability of neurons. And topiramate was originally developed as an epilepsy drug to prevent that excitability, that rapid excitability that's associated with a seizure. And it migrated over to being used in headache. Interestingly, the company, I think it was J&J, that originally developed topiramate for epilepsy had to be forced by the neurology community in the headache space to study and ultimately get an approval for it, because 10 times as much drug was being prescribed for migraines. Now, one of the studies that we did bringing vagus nerve stimulation into this is we did a study up at Harvard and Mass General with Cenk Ayada, in which he looked to see how well we could, with vagus nerve stimulation, downregulate that excitability of the brain, how easily a brain, as you said, how close to the bucket being full and overflowing you could keep an animal. And one of the phenomena that occurs when the bucket overflows is something called cortical spreading depression. We don't have to go into the details of what that is, but he was studying cortical spreading depressions. And what he showed was that topiramate, if given, in daily doses over about a month to 2 month period of time, could downregulate the excitability, sort of empty that bucket. vagus nerve stimulation could do it within minutes to the same degree or a greater than what topiramate could do. So all those topiramate prescriptions that are out there where people are using topiramate to reduce the number of headaches that they're having, reduce their susceptibility to it, well, know that at least in animal studies, we could get exactly the same or better results in terms of reducing that excitability with vagus nerve stimulation in a matter of minutes. And on top of
rather than months,
and with no side effects, because there are significant side effects of topiramate. Topiramate, in fact, it has cognitive effects. It has significant cognitive effects to the point where, certain fields of careers like pilots and lawyers and physicians and people like that, they just refuse to take it. I've spoken with professors and engineers who've taken it, and they just say it makes me feel stupid. So I think it's a great opportunity to maybe wean off topiramate to move on to something else, vagus nerve stimulation, which has the same benefits, offers the same benefits, but does it without the really significant cognitive side effects.
Was this research study that you did with Chenkayata part of that initial understanding that it might have a very positive effect in migraine when you were starting with the vagus nerve stimulation piece? Because I know the history of vagus nerve stimulation started with the epilepsy kind of patients, right? It was the implantation of a vagus nerve stimulator in epileptic patients, invasive device, obviously, to reduce the seizure activity. But was this kind of the link that then brought you to say, well, maybe there's going to be a positive effect in migraine?
Yeah, so it was about 2 or 3 steps that took place. So we were actually doing work, as you know, in asthma and in anaphylactic shock. The work we did in asthma was around the time that we transitioned from having something that was a percutaneously implanted or delivered device, so we had to break the skin, to something that was fully non-invasive. And once we had the fully non-invasive product, we were able to gather a tremendous amount of just experience with it. And what that showed us was one of the primary feedbacks, bits of feedback we got from people was that it was having a benefit on headaches. And so I picked up the phone and talked to headache neurologists. They're not all bad. I spoke to a bunch of them. They were actually quite happy to speak to me. And they revealed to me that, yes, within the epilepsy field, it was already something that had migrated over. They had said, listen, we know the drugs migrate over. We're going to try it with the implanted devices. And so there were 4 or 5 clinical studies. Some of them were retrospective looks, looking to see whether or not vagus nerve stimulation with implanted devices could be beneficial for headaches. Of course, we had a non-invasive device, which made it a lot more useful, not just to reduce the risk of headaches, but to actually treat headaches right away. Because if you can have that effect, that bucket emptying effect, you can have that effect in minutes. Well, now it's something that can be used to treat a headache that you're actually having right now. And that was really exciting to them. And so we were able to recruit them to run clinical studies. What we were trying to do with Cenk was understand, okay, how is it having this effect? What is it? Is this placebo? Is this something that's, is it all just neurotransmitters? And we were really agnostic. We didn't know. And so we went in and we worked with him. He had this model, as I said, of cortical spreading depression. Maybe it's worth explaining what that is. In people who have migraine and people who know people with migraines, you're probably familiar with what's called aura. Okay, aura doesn't happen with every migraine, probably doesn't even happen with the majority of them, but it's considered the classic example of a migraine where about 40 minutes, 45 minutes before the headache occurs, there's some level of visual disturbance that takes place. And I shouldn't even say visual because it's some sort of sensory disturbance. It could be hearing, it could be visual, it can even be in your ability to speak. People can become aphasic. Every once in a while, you'll see some news broadcaster, news reporter who suddenly just starts speaking gibberish. And in that prodromal phase where this cortical spreading depression, which is this slowly expanding wave of depolarization where the nerves in the brain, the neurons, cease to function in a coherent way, and they all sort of get excited, and then they all sort of drop down and become quiescent simultaneously. So I guess there is some synchronization, but it's not in a cognitive sense. And it just, this wave comes through the brain, and that then leads to the pain process growing. So you cycle through that, and then you cycle into a pain phase of the migraine. So he was studying this.
On that synchronization piece, the asynchronicity of normal neuronal function synchronized together in a spreading fashion, is it neuronally driven or is it driven by other cell types?
Very good question. So it turns out that there's a lot of other phenomena that can cause this. Chemical disturbances. It can be driven by literally physically taking a pin and pricking the brain. You'll get a cortical spreading depression that occurs. Another way of doing it is with anoxia. So if you cut off the blood supply to an area, in fact, cortical spreading depressions are a big part of how stroke sort of evolves from the initial damage to what ultimately can be 2.5 times more damage. And that's a function of these cortical spreading depressions. Now, one of the questions I asked pretty early on is, if cortical spreading depressions are negative, and they're having a negative effect on the brain, how did evolution keep it around? Why did evolution not just say, well, that's a mistake, let's get rid of that, let's see that person not survive to reproduce or reproduce less effectively? And so the answer appears to be that cortical spreading depressions, going back to that oxygen deprivation issue, cortical spreading depressions appear to be a signaling message or a signaling mechanism by which neurons who have been starved of oxygen send a message out to the rest of the brain saying, hey, we're starved of oxygen, you better get prepared to be starved of oxygen also. And that would explain, quite a bit actually of the mechanisms that are involved with this cortical spreading depression in stroke and in headache, and how some of the mechanisms for relieving headaches tie into that. But again, they all tie back to what happens when you have oxidative stress. Hand in hand with that is inflammation. They're bidirectionally related. One can cause the other. And so inevitably you end up with inflammation. So you say, okay, what happens when you have this oxidative stress? You start to create a lot of neurotoxic waste. We talked about the glymphatic system earlier. What's one of the really important things you need with glymphatic clearance is you need the release of fluid from the blood vessels. So you need leaky blood vessels. Well, leaky blood vessels are associated with headache as well. So what else do you need? Well, you need to have an inflammatory signaling process that's going to cause that vasodilation. Okay, well, what's one of the most potent vasodilators in the body? It's a substance called CGRP, okay? CGRP, calcitonin gene-related peptide. It's a small peptide, but it's very potent. It's the most potent vasodilator we have. And it's utilized in a lot of different areas. Wound healing. You see a lot of CGRP in a situation where you have a cut or a wound where there needs to be this release of fluid, and you need macrophages or monocytes to come through the wall of the blood vessel and to move into the tissue. So vasodilation is a really important part of that healing process, or at least that initial defending process and ultimately healing process. That's going on in the brain. Now, that's why there's the newest class of drug for headache are these CGRP blockers, inhibitors. They block CGRP. Now, there's two ways that you can do that, or two ways that the pharmaceutical industry has approached doing that. One is to find chemicals, and in some cases antibodies, large molecules, that will bind to that CGRP and prevent it from doing anything, sort of like sequestering it, blocking it. The other is, as I said, the CGRP that's being released has to bind to something, and it binds to the receptors that are on the blood vessels. So you can block those receptors. You can bind to those receptors in a way that sort of shields them from the CGRP being able to act on them. Both of those types of molecules exist both in small molecules and in large molecules in the market today. Things like Aimovig, Ajovy, et cetera. But why not block CGRP from ever being released in the first place? Well, what prevents CGRP from being released? What triggers CGRP from being released, we know, is inflammation. So if you block inflammation, you'll block the CGRP from being released. So we went and we did studies also, not only looking at these cortical spreading depressions, but looking at, okay, what's the effect of vagus nerve stimulation on the release of CGRP? And we found that CGRP release doesn't happen as a result of vagus nerve stimulation. So again, if you're on Aimovig, or if you're on Ajovy, or if you're taking these other drugs that are blocking CGRP from being released, blocking CGRP once it's been released, why not block the inflammation first? And then you don't have to take those drugs. And it's so much easier. And you don't have to worry about the potential side effects of blocking CGRP when you need it.
Yeah, throughout the rest of the body.
Yeah, I mean, your eye, your retina is covered in CGRP receptors. Your heart is covered in CGRP receptors. Do you really want to block those? I personally think that, and they haven't done this study. Again, FDA didn't ask them to do it, and so they're not going to do it. But my suspicion is that if you did an animal study looking to see the rate at which you heal cuts or injuries is actually impaired by those drugs, that you are not going to heal. Maybe you'll still heal, but how quickly you heal, to me, I mean, if you get a cut, you want to heal that as quickly as possible. You don't want to have an open wound. You don't want to have a way for bacteria to get in. And you want to make certain that if bacteria does get in, that you have vasodilation there so that you can get your immune cells in there to stop that. Are you going to have a higher level of infections as a result of CGRP usage? I don't know. Theoretically, these are concerns that scientists would have, and the studies haven't been done to show otherwise.
This is interesting because, as you're mentioning the CGRP piece and just the importance of being able to heal more quickly, right? Or being able to heal, I guess, in general, you want to have the resilience to be able to heal quickly. But a CGRP agonist would absolutely limit that resilience, or it would decrease diffusely throughout your body your ability to create that resilient recovery process. So it's actually counterintuitive. Sure, it's symptomatic reduction in CGRP and thus ideally shutting down the migraine feeling or the experience, but at what cost? And the cost is likely to be based on what we're alluding to here, and obviously there isn't research on it directly, but the likelihood is that your wound healing and your overall bodily resilience is decreased because you have the CGRP agonist running through your bloodstream.
Yeah, I mean, listen, you go in for surgery and they ask you, are you on a blood thinner? Are you taking an aspirin a day? These things can change how much you bleed. Well, how about how susceptible are you to infections? We ask, are you on an some immune regulator or
like a steroid hormone or like a cortisone or something like that? Yeah, exactly.
Humira or Enbrel. I mean, you've got risks associated with these things. Is this a risk you want to take? Now, you might say to yourself, listen, I get 15 days, 20 days of migraines per month. My life is miserable. I have to go on these things. Understand, I completely sympathize with your decision. But have you really, truly investigated the alternative options that might provide you the same benefit because they're doing the same thing? And vagus nerve stimulation is doing that CGRP blocking that you're looking for. You may find that it's able to do the CGRP blocking locally in the brain and not systemically, and so that you'll still be able to have a normal healing response, but you won't necessarily be suffering with the headaches any more than you would if you were on the drug. I mean, so I just encourage people to look and compare and recognize that the scientific mechanisms are there to support vagus nerve stimulation as a use in migraine. Actually, the FDA has cleared it for acute headaches and prevention of headaches in some of the most severe headache types that exist. Migraine, cluster headache, Sankt and Suna, and got these thunderclap headaches. It's just, awful.
That's right. I'd love to get into some of the underlying mechanisms, how vagus nerve stim works to downregulate, not only symptomatically, but to actually downregulate the inflammation that is the underlying driver of that migraine experience. We've talked a lot about the cell types that are involved in that inflammatory process, particularly the microglial cells and tissue-resident macrophages and every other organ of the body. But let's talk about the neurotransmitter effects of vagus nerve stimulation, something that will then have an effect on those tissue-resident macrophages, those microglial cells and other cell types.
Yeah, and it's worth going back and thinking about this historically because vagus nerve stimulation was introduced for the treatment of epilepsy, as we talked about before, and it migrated over, at least initially, using implanted devices in small studies to study its effect in headache. For about 20 years, maybe even longer, 20 years after the devices were approved, the implanted devices were approved, it was the standard position of the field that the way in which vagus nerve stimulation was having its effects was modulating neurotransmitter levels. And specifically, it was looked at as being triggered by norepinephrine release. So basically, the structure of the brain that is responsible for the release of norepinephrine is called the locus coeruleus. It's in the brainstem. It's a very, very low in the brainstem. It's a very important structure. It's relatively small. It's only a few 100,000 neurons, but it supplies the entire brain with norepinephrine. Okay, and it's the most widely distributed network, and it releases norepinephrine both synaptically, which means at a synapse, as well as through what's called volume transmission. So there are these little spots that look like they would be synapses, but they actually are just releasing it into the interstitial fluid.
Almost like an amplifier.
Yeah, it's just sort of like, it's almost like your irrigation system for your lawn,
or like a speaker.
Yeah, it's just releasing it everywhere. The interesting thing is that your norepinephrine is a very powerful neurotransmitter, and it doesn't last very long after being released. So once it's released from the cell, there are mechanisms that break it down very, very rapidly. And so when they did the original studies in epilepsy in animals, they looked and they said, okay, this is the way anatomically the signal comes up through the vagus nerve, and it first hits in the nucleus tractus solitarius. It hits the locus coeruleus. And the locus coeruleus is where you're going to release norepinephrine. So norepinephrine must be really important. So what they did was they looked and they said, okay, well, what happens? Does vagus nerve stimulation still work if we somehow preferentially lesion away, get rid of the locus coeruleus? And lo and behold, it didn't work anymore. And so they said, we found the spot that's the most important. It makes logical sense. When the locus coeruleus is there, vagus nerve stimulation works. When the locus coeruleus has been sort of burned away, it doesn't work anymore. So everything must be the result of norepinephrine. Now, a acute listener will realize that that's not exactly logically consistent. It sounds good. When the locus coeruleus is there, it works. When the locus coeruleus is gone, it doesn't work. But what if we say the locus coeruleus is there, but something else isn't there? Does it still work? Or, is the locus coeruleus and norepinephrine release just one step in a process? And that's where some intelligent people out there started looking and saying, okay, well, what else gets activated? Okay, it goes through the locus coeruleus, but then where does it go? And the people looking at epilepsy said, well, right next to the locus coeruleus is an area called the dorsal raphe nucleus. And that's where serotonin is released. And so they looked and they said, hey, you know what? What's happening is when you stimulate the vagus nerve, serotonin levels start to go up. Maybe that's part of the equation. And so they looked and they found out that, yes, in fact, if serotonin levels don't go up, it doesn't work as well. And serotonin, they said, well, serotonin, we think of serotonin as like the happiness molecule that's related to depression. And lo and behold, they went back and they looked at clinical data and they said, hey, vagus nerve stimulation is helping with depression too. And they said, that's cool. And then what subsequently is done by Aegea and other people, and we've been part of this, is, well, what else is getting activated? Well, it turns out that the nucleus bacillus of Maynard is being activated. And what's that? That's the brain's, much like the locus coeruleus is the only source of norepinephrine, the nucleus bacillus of Maynard is the only source or the primary source of acetylcholine. And so, yes, you're getting acetylcholine release. Interestingly, acetylcholine release, just looking at this paper the other day, much the same way norepinephrine is released everywhere in the brain when the locus coeruleus is upregulated or activated, and that a bunch of it is released through this volume transmission where it's not actually at synapses, it's just being released into the interstitial fluid. Somewhere between 86 and 93% of all of the acetylcholine that's released in the brain is released in the same way through non-synaptic release. It's volume transmission. And you say, well, okay, the acetylcholine and you got norepinephrine at some level, if you've listened to some of the podcasts we've had before, you'd recognize that they sort of are opposing one another. Well, isn't it very interesting that when you stimulate the vagus nerve, while the stimulator is on, the locus coeruleus is being activated and you're seeing the release of norepinephrine. But that is very rapidly broken down. Literally within seconds of turning off the stimulator, the norepinephrine levels have come down dramatically. But the triggering that did of the dorsal raphe nucleus for producing serotonin and the nucleus bacillus maynards for the release of acetylcholine, they persist. They're the light switches. Now you've turned them on and they stay on, okay? They're not like the motion detector where it turns off. Those light switches stay on and they stay on for hours. And so even though you get that initial burst of norepinephrine, it's the other areas that are really important. So it turns out that if you suppress acetylcholine, if you put in medications or chemicals that will block the cholinergic activity, vagus nerve stimulation doesn't work anymore. It doesn't have the effects. So again, you go back and you say, well, what they did was they looked and they said, oh, when the locus coeruleus is there, it works. When the locus coeruleus is gone, it doesn't work. Yes, but if the locus coeruleus is there and you block the cholinergic activity, it doesn't work anymore. So I think we're coming around to realizing that all three of those neurotransmitters, and there's parallels with dopamine and oxytocin and other things, that when those other areas aren't allowed to participate in the process, then vagus nerve stimulation doesn't work anymore. And at least according to the research we have right now, the most important one of those is the acetylcholine because of what it does to the immune cells. But that's something that needed to evolve in our understanding over time.
There's something that you said there, and I want to just kind of dig into it a little bit. Initially, you mentioned the norepinephrine release that occurs at the locus coeruleus is primarily synaptic, but there is volumetric release as well. Mm-hmm. But in the nucleus bacillus of Maynard's, the acetylcholine release is largely volume release. Volumetric release.
I would say I wouldn't say it's necessarily with norepinephrine largely synaptic. It's both. It's
a bit of both.
But
it's only on short term as well.
It's only on for short periods of time, and the norepinephrine doesn't last very long. I mean, the acetylcholine, don't get me wrong, acetylcholine is also broken down very rapidly, but it's continuously being released.
Stays on.
Whereas the norepinephrine, which also breaks down quickly, but it's not continuously released.
So what's interesting here is you'll get the initial burst of alertness with that norepinephrine release that's occurring right away. So from a mental cognitive perspective, you'll notice clearer focus, clearer thought, ability to focus on things a little bit more attentively, just that alertness that comes from it. But then there's almost like a calming effect that remains long term. And that is primarily driven through the serotonin, which is longer term, and the acetylcholine, which is longer term. And because it's volumetric, the primary target is not neurons, but rather the cells around those neurons. And the cells around those neurons are the immune cells, the microglial cells, the astrocytes, with them then being downregulated, and acetylcholine then having its anti-inflammatory effect or downregulation of inflammation effect. So that's where the inflammatory control piece comes in to downregulate and kind of shut down the symptomatic nature of the cortical spreading depression, the inflammatory response, all of that being downregulated is through the acetylcholine primarily.
Right.
Is that right?
Yeah, that's largely correct. And what I would add to that is I would say that when we use language like saying, well, vagus nerve stimulation and the release of acetylcholine, downregulates microglial cells. If by downregulate we mean that it stops them being inflammatory, that's correct. But I just want to caution in general people taking that to mean that we put them to sleep. Because in fact, we do the exact opposite. Okay. When vagus nerve stimulation is releasing the acetylcholine, and acetylcholine is binding to the alpha-7 nicotinic acetylcholine receptor, and we're downregulating the inflammatory posture of these microglial cells, they actually become more active. We're saying we're deactivating them, but we're not. What we're doing is we're actually changing their physical shape. They go from being sort of this angry amoeboid shape into these, they've got these long, tendrils that are reaching out and touching what we call them processes. They're going out and they're touching the synapses. They're doing their surveillance work that is critically important for learning and memory consolidation and alertness and making certain that our brains are functioning, clearly. So inflammation causes brain fog, okay? But clearing that inflammation up with acetylcholine release it may make us feel calmer. That doesn't mean that our brains aren't functioning more efficiently and more effectively. Because I'm dealing with this right now in the studies of sleep, because we're thinking to ourselves, well, do we want to use the vagus nerve stimulator right before the beginning of sleep? Because there is this initial norepinephrine release that causes people to become alert. But all of our experiences tell us that, yes, you're not going to fall asleep in the middle of stimulating. I mean, it's not like you're going to have the stimulator on and you're going to go like this while you're sleeping. But what you are going to do is shortly after, within seconds after stopping it, you're going to feel that wave of relaxation as you begin the process of bringing those microglial cells back down into that state where they're active surveillance and doing all the neurotrophic things that we want them to do. If you're not tired, you're going to be awake in a calm state, thinking more clearly and broadly, but you're not going to be somehow forced awake by norepinephrine. It's not that sudden jolt that you're just going to be steadily awake. And if you choose to then fall asleep, you're going to fall asleep very easily because there's no stress, because you've removed the stress.
I will attest to this personally. I use this for myself. I use this with my daughter. So I have an almost 8-year-old daughter. We'll say 8 because it's 2 weeks out. And she is an avid baseball player. And even just last night, I'll give you the example. She came home and she was ramped up after her baseball game. I'm her coach. She got 2 wonderful hits last night. It was her first game of the year. She was just so excited. She was like, I just want to tell mommy about my amazing game. And I got these 2 hits and she played really well. But, when you're ramped up, it's really hard to fall asleep. This is a very common issue, in fact, for professional athletes. They tend to play later in the day. Their games are 7 p.m. locally, go until 10 p.m. They have a lot of trouble winding down and going to sleep. I've spoken to a lot of friends who've worked with professional athletes, and like bedtime is 2, 3 a.m. because
I'm sure that
they are just ramped up.
NBA fans probably had a pretty difficult time falling asleep last night, if they were Knicks fans or Nuggets fans, because I'm dating when we're crazy.
How the Knicks beat the Celtics, I'll never know. That was amazing.
Listen, and Jokic, and down the stretch, that shot by Gordon, oh my gosh.
Wow.
Anyway.
Wow. That ramp down, that bringing her down, I made sure we stimmed as soon as she got on her bed. So she, brush her teeth, gets in bed. And I didn't even question it. We were putting it right on, calmed her right down. It took a few minutes, obviously, for the full ramp down to take place. But those 2 minutes are spent stimulating, calming, relaxing, and not 10 minutes later was she asleep.
Yeah.
So
I see this every night. My wife has, a very successful business. She typically works after dinner, and she's, staring at the blue screen. She's doing all the things you're not supposed to do, stressed, etc. And, looking at her iPad, reading emails. And, I walk in, and if I'm a night owl, so I'll stay up late. But on nights where I'm, getting into bed at the same time, I'm just expecting that she, given her high stress level, will stay awake for, a long period. She stims. She's asleep before I am. And I think I fall asleep fast. She falls asleep like before I do because of it.
So on the sleep side of things, absolutely. I think that is important for people to note, that it's not there to push you awake. That said, there are certain people that find the stimulation to be exciting. So if that happens, be aware. I had a Parkinson's patient who found every time he stimmed, his energy was just through the roof. So we made sure that his stimulations were morning and middle of the day rather than evening, and he was able to get to sleep far more easily.
That actually I've seen before in movement disorder patients. And part of the reason is, I think, because they're used to energy expenditure associated with some of the symptoms of the movement disorder. And when they're relieved, there's this excess energy. In fact, you see it. There's a lot of people who have essential tremor and Parkinson's disease who are very frail. They look very thin. And the reason is actually they are expending a tremendous number of calories per day because of that movement and that muscle, tonicity issue.
Yes.
What actually ends up happening when they have deep brain stimulators, the thing that got me into this field to begin with was essential tremor and Parkinson's disease, deep brain stimulation. one of the consequences, one of the side effects is almost like that professional athlete who stops playing professional sports and gains 50 pounds. These people gain a lot of weight, and they do because their bodies are no longer in that mode, and they've become used to eating a number of calories just to sustain themselves that is far higher than what you would think their activity level really is. And so, same sort of thing. You calm that energy expenditure, but at the mitochondrial level, at the rest of the level of your expectation for activity, you still got a lot of energy.
Excess energy. Yeah.
So
That makes a lot of sense.
that is I would imagine that that's something that with time will downregulate, but initially,
in the initial stages,
that being an issue.
Let's wrap this topic up with a nice little bow here on migraine and vagus nerve. We know that vagus nerve stimulation in particular is a wonderful tool to help with not only acute vagus nerve or acute migraine issues, but very much so in the prevention of these issues. And it comes down to the bucket emptying response or the bucket emptying functionality of vagus nerve stimulation. It's almost like you're adapting to stress more easily. You're able to empty out or at least lower the contents of that bucket when you do vagus nerve stimulation practice, whether it's humming, chanting, gargling, deep breathing, exercise, cold plunge, like whatever those tools are that you utilize, they're going to have these effects. Now, some of them won't happen quite as quickly or as rapidly. I can tell you from my experience with my patients, nothing has worked as fast as electrical vagus nerve stimulation, and nothing generally that I've utilized is as safe as non-invasive vagus nerve stimulation on the neck. The fact that with a 2-minute stimulation that you can have that upregulation of norepinephrine and serotonin and acetylcholine occur within the brain, the regulation of those immune cells, the downregulation of the inflammatory processes and the upregulation of the regulatory processes of these microglial cells that shift towards the M2 state, which we didn't talk about much today, but that's exactly what the changing shape of those microglial cells is going to do. That's how we downregulate CGRP release. That's how we downregulate the inflammatory nitric oxide, inducible nitric oxide piece. But those are, again, symptomatic. It's the underlying issue is there's an inflammatory trigger and that bucket is full. So what can you do to empty out or lower the contents of that bucket? That's where vagus nerve comes in. Any final thoughts there from you?
Yeah, I think you've really summed up that really well. I would just add one thing. If you're a migraine sufferer and you only have migraines, I mean, it is completely, you have no other problems whatsoever. No depression, no anxiety, no insomnia, no issues with pain, no gut issues, none of those things. Then you're a rarity. Okay, you're a relatively rare case, and vagus nerve stimulation should be beneficial, but that might not be the reason why you're experiencing the migraines. It may be something else. But for the vast majority of people who suffer with headaches, it could be stress. It could be insomnia. It could be, I said stress, but anxiety. It could be depression. It could be gastroparesis or gut motility issues. Any one of those things is indicating that you have this bucket issue that we're talking about, this bucket that's overflowing and you're experiencing. Think of each one of those problems as a symptom. It's a symptom of an underlying problem, and vagus nerve stimulation treats that problem. It could be inflammatory. It could be autonomic nervous system. The thing that causes that stress and that stress response is being in that fight or flight mode. And if you're in that too long, inflammation occurs. So all of those other symptoms that you're experiencing are really just signals of this underlying problem. And if you treat with vagus nerve stimulation, you're going to find that all of those symptoms get better. And that's what, I ran a study personally over in the UK on 1,000 patients who were all multi-symptomatic patients. And the results were phenomenal. I mean, that's where you really see the benefits. So I hope if you one of those people, by all means, try it. You cannot hurt yourself, and it will be life-changing. The number one thing we hear from people who start using it, who are in that boat, is thank you for giving me my life back. In fact, I'm going to say one last thing about this. The reason you probably are resonating with what I'm saying, the reason you are experiencing this and understand this is because my bet is that all of those symptoms either arrived in your life around the same time, or when one started, the next came and the other ones came very in rapid sequence thereafter. If you're one of those people, you know what I'm saying is true. It's resonating. I had grown men break down and cry saying, I've been telling my doctor this and he won't listen. Okay. I'm telling you, vagus nerve stimulation, if you're in that group, vagus nerve stimulation is the way to go.
I don't think we could said it any better. I want to wrap this one up. If you or somebody you know has been suffering with migraines, please share this episode with them. And we really, truly hope that you'll take a look at and research vagus nerve stimulation, because we as researcher and clinician have seen phenomenal results for so many people that are suffering. We really just want to see people benefit in a very positive way. We want to see everybody not suffer from this debilitating issue anymore, and to understand that it may not be curing the condition, but it's enabling your body to enter a state where the healing can take place, where inflammation can be controlled, where the root cause can be identified and eliminated, and you can then get your life back. So I hope this has been a beneficial episode for you. Please share this episode with one person who you think could benefit from hearing this information. And thank you all again for the support. We will catch you all on the next one.